Shall we all start off with the interpretation? The Videonystagmography systems will be there in the hall throughout the day. So even at the end of the day, again you can come back and spend how much time you feel like spending there for the hands-on experience of the Videonystagmography system. The idea of this present session of Videonystagmography session before this interpretation is to get an idea sufficient enough for us to follow the present workshop. Start. Shall we start? Yeah. So here we go. So this is about helping all of us understand how to go about interpreting the Videonystagmography graphs. Okay. Anantu has already given a brief introduction about the conventions, and all of you had some experience with using the goggle, and so based on that I will proceed. So for each eye, how many traces are there? For each eye, how many traces are there? For each eye? 2 traces for each eye. So there are basically 4 traces. In case where there is a target to be followed for each eye, again there will be 2 traces, but only horizontal or vertical. So for the right eye, in balance eye, for the right eye, the horizontal means right and left movement is shown by which color trace? Which color? Red. The right and left movement, that is the horizontal trajectory movement for the left eye is shown by which color trace? Blue. Okay. For the up and down, that is the vertical movement of the eye, it is shown by which color trace? Black. And the other eye, for the left eye, it is a little purplish. Both of them look almost clear black. So that is the basics. Now, So we'll proceed with the interpretation. So just to make sure that we are all on the same page, if somebody has not understood this particular thing, I can spend some time because this is very important, post which we will start, because most of us are not VNG users. So we should make sure that we understand this particular part before we proceed. Okay? Okay. Now something like this is how the graph line looks. This is the time graph. Is that right? The horizontal axis represents the time. Is that right? You're all with me? Okay. On the vertical axis, you see a 0 written here, and there is 10, 20, 30, and then there is -10, -20, and -30. Correct? Please be with me. Is that right? Okay. Now, if I draw a trace like this, what does this mean? The eye has moved? The eye has moved? Right side. Okay. Now, if I draw a trace like this, what does this mean? The eye has moved? Left side. Okay. From where did it go left? Okay. So this 30 degrees tells, this 0 degree tells that you are looking straight ahead. And all these things is little rightwards, more rightwards, and more rightwards. This is leftwards, more leftwards, and more leftwards. So whatever is in the 0 is right in the center. Okay, fine. Now let us see the different. Now if there is a eye tracing which goes, excuse the little bit of slant. If this kind of a tracing is coming, what does it mean? The eye is looking straight ahead. It means that the eye is looking straight. Sir? Sir? The eye is not moving in the horizontal plane. Yes, sir. Yes, sir. Yes, sir. No movement. So flat is no movement. Now, after a proper calibration, if the same tracing instead of here, if the tracing came here, what does it mean? Eye is looking at something to the right, correct? Now, if it comes here, it means the eye is looking something further to the right. Is that right? And if it was here, it is to the left, and it is here means it is much further to the left. Okay. Now, this trace means moving to the right side. This trace means starting from the right, crossing the midline and going to the left. So much. Fine. Now, in the beginning it goes slow, but afterwards we'll pick up pace. We need to be sure that all of us understand this. That's why. Now, if I write two lines, this one and this one, which is faster, this one or this one? The second one is faster, the first one was slower. Both of them represent that the eye is moving to the right side. Okay. This versus this. Which side the eye is moving in these two? Left side. Which is faster? The last one, correct? So this is the faster movement, this much. Now let us go into the details. When we talk about videonystagmography interpretation, this has to happen in 3 steps. First is in understanding language. What are the 3 things we do? First is we know the alphabet. Is that right? Then using the alphabet we write words. And then using the words we make meaningful sentences. Is that right? In videonystagmography, the alphabet is 3. What are those? There are 3 alphabets. One is this one. What does this alphabet mean? A straight horizontal line means no movement. This is no movement. No movement in that particular plane. That's all. It means no movement in that particular plane. Next. This is slow movement and this is fast movement. In this, there is one thing we need to know here. This no movement is an absolute alphabet. No movement is an absolute alphabet. Okay, no movement is an absolute alphabet. Slow and fast are not absolute. They are relative to one another. They are relative to one another. So, if you have 2 lines, one line which goes, if there are 2 lines, if there are 2 lines like one is like this and another is like this, here, which is the slow movement? The first one. Which is the fast movement? The second one. If there are 2 lines like this, okay, this is more slower, this is slower than, this is faster than this slow, but then, so what you say is, this will be the slower one, this will be the slow one, and this will be the fast one. So the first alphabet, that is the this is the no movement. This is an absolute alphabet, but these 2 things are relative to one another. You see 2 segments and tell of the 2 segments which is fast and which is slow. It is not like there is one particular trajectory line. Anything below this is slow, anything above this is fast. It is not like that. It is always relative to one another. These are the 3 alphabets. Now, once we know these 3 alphabets, we can know whether the eye is in one place, whether the eye is moving, whether it is moving fast, whether it is moving slow. Based on this is what we make up the words. First is alphabets, then the words. Then we form sentences. So let us go to the words. Okay? What are those words? First and foremost, which Anantu. Okay. First word, let us see. So the eye is moving. There are two segments here. Okay, I'll draw a little better. There are two segments here. Fine. So which alphabet is this compared to this one? This is slow. This is fast. So this eye is moving slowly in which direction? Fast in which direction? Slowly to the, all of you. Fast to the, so which beating is this? What is this? This is a, if it keeps repeating, this becomes a left beating nystagmus. It becomes a left beating nystagmus. For ease purposes, I will only be concentrating on the horizontal direction. Later on, we can build this for the vertical. Okay? So this is a typical jerk nystagmus. What is the characteristic feature of a jerk nystagmus? That there is going to be one slow component and then there is going to be one fast component. Is a typical feature of a jerk nystagmus. Then there are other varieties of these things. In the workbook, there are a lot of other examples that are there. So now we will be able to define. So I will draw some things. You tell me what it is. Okay? Fine. So what is this? This will be a right beating nystagmus. Is that right? So this is a right beating nystagmus. Now we will build on something else. Okay? Now I will write something. I am not writing the numbers there. Now, what is the meaning of this one? The eye is stable or not moving and looking right in the center. Is that right? Now, what does this mean? Now the eye looked to the, it went to the right side. Now it is looking on the right side. Now it went left. Here it is looking to the left. Fine? Okay. Now what shall we do? This eye. What is this? What is this? Right beating nystagmus. So what we saw two alphabets. There is a slow movement and a fast movement. Slow movement and a fast movement. Slow movement and a fast movement. This is a right beating nystagmus. Now, it is not just about right beating nystagmus. What is this? Right beating on right gaze. Right beating on right gaze. So that is the key point. Now, when you go back, this is right beating on left gaze. So this is a typical direction fixed nystagmus. Whether you look to the left or to the right, direction is not changing. Direction remains fixed. But what changes? The intensity changes. This is something that called, this is the nystagmus which is considered to follow the, which law? Alexander's law. Control. Now, sorry. What is this? What nystagmus is this? Here, where is the eye here? Is it in the center, to the right or to the left? Right, because this is the 0 point. This is all to the right side. This is all to the left side of the center. So here the eye is looking at the, right side and the nystagmus is right beating. Here the eye is looking to the left side and the nystagmus is left beating. So this is the typical gaze evoked nystagmus. Fine. So now we saw the nystagmus. This is the typical jerk nystagmus. Jerk nystagmus generally has, what does jerk nystagmus have? There is a slow and a fast component. If there are two slow phases, then it is considered as a pendular nystagmus. So pendular nystagmus has two slow phases. Jerk nystagmus has one fast and one fast, one slow and one fast, one slow and one fast phase. So these are the two things that we know. So what all, as of now, which three alphabets we know? What are those three alphabets? No movement, fast movement, slow movement. Using those alphabets, we know two events or two words. What are those two words? One is a jerk nystagmus, the second one is a pendular nystagmus. So now let us identify a few more of these words. Shall we? Now, if this is the point of fixation, okay, I'll write a dashed line to represent a point of fixation. If this is the point of fixation, now, if the eye is fixing on this, suddenly it makes one jump of around 2 degrees to the right, then it is there for around 200 milliseconds or less than 200 milliseconds, and then it comes back. Goes up, less than 200 milliseconds, comes back. It keeps coming back to the line of fixation. But then it goes, it spends some time there, realizes that I have missed what I am supposed to be looking, then it comes back. So this word is called, this is a small saccade, there is a fixation event, there is another saccade back to its fixation point. So what are the three? There is a fast movement, there is no movement, fast movement. No movement, fast movement, no movement, fast movement. It looks like a square. So this is called a square wave jerk. Square wave jerk. This is called a square wave jerk. Fine? This is called a square wave jerk. What is a jerk? A jerk is something where from I am standing here, something is here. If you push it in one direction, it goes there and then it comes back to where it is. This is a jerk. Versus an oscillation, which is a typical pendulum. Okay, in a pendulum, if you see a pendulum, oscillation is where it goes to both sides and comes back. Correct? It goes this way, then it goes this way, then it comes this way. This is an oscillation. But if from one place it is just sent to one side and then comes back, it is called a jerk. So we should know the difference between the jerk and the oscillation so that we know the further words. Shall we continue? We are all together? Yes. So if it is a small one, it is called a square wave jerk. If it is a big one, this becomes a similar, but the oscillations are bigger. This will be called a macro square wave jerk. It is macro, but it is a square wave jerk. Fine? Sir? Yes, sir. I am just following the terminology. Yes, sir.
Should know that it's either the macro saccades or
yes,
it's a saccadic eye movement.
Yes, sir.
So this macro square wave it's a saccade.
It's a saccade. It's a saccade.
The normally saccade should be like involuntary.
Yes,
you are
sir.
following object.
Yes, sir.
So if it occur involuntary without in darkness or something.
Yeah. Yes, sir. Yes, sir. Now I would want you to just open page number 18, this kind of pages, which will first are all images with Anantu, all the dance moves. Next, page number 18. So here are the descriptions of all the different kinds of these other words other than nystagmus. So if the key point here that I wanted to stress here is every eye oscillation is not a nystagmus. Every eye oscillation is not a nystagmus. We first saw a jerk nystagmus, then we saw pendular nystagmus, then we saw square wave jerk, and then we saw a macro square wave jerk. Fine. So we saw those two things. Then is the microsaccadic oscillation. So we saw the difference between a jerk and a oscillation. So in a jerk, if there was a point of fixation, if there was a point of fixation, the jerks always happened, always brought the eye back to the point of fixation. Whereas, if it is an oscillation, something called the third one, macrosaccadic oscillations, you see the picture on the next sheet. What you see here is, if there is a point of fixation, it goes in one side, then it goes back and forth around the point of the intended point of fixation. So this will be a macrosaccadic oscillation. This is the next word that we need to understand when it comes to videonystagmography interpretation. Fine. Next, we are supposed to see is what is the key feature in all the things that we saw is, once the eye goes in one direction, it spends some time there. There is a no movement phase. There is a phase of this particular phase. What you saw here is a phase of this particular point here. You saw a no movement phase. Is that right? And then it comes back, which means there is a short latency before the eye starts coming back to or going to the other side. So this is typical. This is there in square wave jerks, micro square wave jerks, and also in the macrosaccadic oscillations that we saw. This is the macrosaccadic oscillations that we saw. We know the difference between a jerk, only one side, and an oscillation which goes to both sides. Now, coming to the next one. If this same thing happens only in the horizontal plane, without a latency. So the previous thing what we saw is, there used to be, it goes in one direction, there used to be some amount of time spent latency and then comes back. Time spent and then comes back. But without any time spent, without any latency between the alternating saccades if it happens, and if it happens in the horizontal plane, then it is the next word. What is that? It is called, what is it called from the book? What is it called? What is it called? It is called, if it is only in the horizontal plane, it will be called as ocular flutter. But if it is in multiple different planes, then it will be called as opsoclonus. That is all. Okay, if it happens in multiple different planes, it will be called as opsoclonus. So these are the different kinds of events that we should recognize when it comes to, these are the different kinds of words that we recognize. So we recognize slow movements, fast movements, and no movement as the three alphabets, and then we know so many words. Now shall we start going to the little more advanced words, and then after that we will form sentences. Shall we? Now, please open in the BalanceCon 2019 Mysuru, the first page here. Hypometria. Okay? Now let us give the eye a task. Shall we give a task to the eye? Let us give one particular dot here. The eye has to look at this dot. Then the eye has to look at another dot to the right side. Fine? If the eye, now the instruction to the eye is move between these two things. Now start from here and go here and stop in one jerk. Now let us imagine if this eye has a problem. Okay, if this particular person has a problem in measuring distances and he underestimates the amount of distance that needs to be covered. Underestimating the distance. What is that called in cerebellar sign? Underestimating the distance? Hypometria. So what will happen if this is 1 meter? Just say this is a 1 meter distance or something, for whatever, or some number of distance. I am just using an arbitrary 1 meter distance. So if it is a 1 meter distance to be covered, how many ever degrees of arc it says depending on the distance. If the person is underestimating, what will happen is, say he is underestimating by 10%. So instead of covering in one go, what he does? He covers only say 90 centimeters, and then he stops there for some time. Then he realizes, no, I have still not met the target. Then he goes and fixes. Is that right? How will this appear on a graph? We all know this is a rightward movement. So the eye will, let us say that This is the place of the, on the graph. This is where the target is supposed to end. This is where the target is, this is the first point. This line, this is the second point, rightwards. Is that right? You're all with me? You're all with me? Yes? The S should be a bigger S. Yes. So now if I am writing this as a VNG trace, okay, this is the VNG trace. This is the point of beginning. This is the end point of the target. Now if the eye has to move from that place to this place, now from here to here it did not reach, it fell short. So the eye starts from here. It did not reach the target, it fell short. Then it was not moving for some time. Is that right? And then it makes a final further correction and reaches the target and stays there. Okay? Is that right? Will that how hypometria will look like? But then when we see the videonystagmography studies of several patients, you will see that this particular finding of a little bit of hypometria is normal for a lot of people. For a lot of people. Then how do you say whether it is a real hypometria because of real underestimation of distances or not? So let us go back to this one. So if this particular person, he starts from here, he goes here 90 centimeters. So if it is a continuing problem, if he underestimated by 10% the 1 meter to 90 he goes, for the next thing he again makes the underestimation, right? He will not again reach. Now he covers only 9. Then he goes 9 mm. Then he makes a further correction and then reaches. Is that right? He takes it, he does this in steps. So when you look at the picture, the hypometria picture that is presented there, you will see that the eye tracing looks something like this. It goes there. There is a stop. It realizes that I have not. Again makes one more correction. Again it underestimates the distance, but by a lesser extent because the distance is less. Then takes one more step to reach the target. So there are multiple steps, not one step, but 2 steps, sometimes 3 steps at the end of the saccade. This is how the hypometrias look like. Can you make out that particular thing in the book, workbook? Hypometria? Multiple steps before it ends? All of you can see, who all have seen, please raise your hands so that we can go further. Super, great. Now, I want you to just turn your pages back and go to page number 19 here. Page number 19. Okay. Now, just see the first picture A in page number 19. Now I will tell you something. Okay, let us go to little bit more of understanding. Okay, now this is the place where the eye should start. This is the end point of the target. Now let us see the other problem is there in the saccade. What is this other problem? The other problem is overestimation of distances. If there is a overestimation of distances, the eye starts from here. Instead of covering 1 meter, it covers 110 centimeters. Correct? There is a overshoot. Now, when the eye turns back, if it is a hypermetria in one direction, then again, it turns back, then again overestimates, then it goes to this side. Then again, then it comes back. So, in case of previous example of hypometria, what we saw in hypometria was, in hypometria, there is an underestimation, it falls short, again it falls short, and then it reaches the final point. Whereas in a hypermetria here, it goes beyond the target. If this was the target where it is supposed to end, it goes beyond it, stays there for some time, realizes that the eye has gone beyond, it goes back. When coming back also, again it does the overestimation. Then only it comes back. So there is an oscillation. So here you see, in hypometria you see steps, in hypermetria you see oscillations. Oscillation around the point at which it is supposed to fix. So that is the first picture that you see. A. Can you make out that in the book? Yes. That is how. There is an oscillation. That is from the Z book. Okay, Lee and Z, neurology of eye movements. Now, what if, okay, there are two, in the eye movements, there are no movements we saw, and there are saccadic movements which are considered as, saccadic movements are considered as ballistic movements. And then there are the slow movements, okay, which are more like a pulling movements. What is the difference between these ballistic movements and the other categories of slow eye movements? What do you mean by ballistic? Ballistic is something like, what is this? A rocket. Thanks, somebody understood my diagrams. Okay, so rocket. How? Okay, like that. This is a rocket. Okay, this has both. Okay, continuing thrust and this thing. Like, but if you're throwing a ball or some projectile, or if you're taking an arrow, okay, if you're taking an arrow, okay, and then firing an arrow, shooting an arrow, what does it mean? How does the arrow move? How much ever distance should go in the arrow is all given in the first one go. Where this arrow exactly lands is decided right here in the beginning. Once you have let go of the arrow, you don't have any control over the arrow. Is that right? So, depending on what distance you want to cover, that much of energy you will put here only. Is that right? Yes or no? So, this also means that if the arrow gets a higher initial velocity, it goes to a farther distance. If it has a lower initial velocity, it goes to a shorter distance. Is that right? Okay, so you can look at the velocity of the arrow and tell where it is going to land. Is that right? Yes or no? Okay, so initial velocity, if somebody told, okay, it started at this much. It started at 50 kilometers per hour. That means it is going to land here. If it is going to be 100 kilometers per hour, then it is going to land further away. Is that right? Yes or no? Okay, so that much. So it is all. In the eye movements, saccades are considered as ballistic eye movements. Saccades are considered as, what are they considered as? They are considered as ballistic eye movements. Versus in the other slower eye movements, they are like pulling a cart. As long as you pull, it comes. If you stop, it stops. There is no initial charging, something like that, and it decides where it lands. So, if somebody has to move from one particular point to another particular point, okay, versus from this point to this point, the velocity, that initial velocity is going to decide whether it is going to land here or whether it is going to land there. Fine? If there is a miscalculation of the initial velocity, instead of going from here to here in one go, the eye will take, if there is an underestimation of how much is there, what will happen? The eye will reach up to here using a fast movement. From there it will resort to another category of slower eye movement to get pulled there. Yes or no? Yes? Okay. So when you see the next one, you see the second picture after hypometria in this page. Balance Con 2019 Mysore. Look at the left eye graph versus the right eye graph. Left eye seems to reach its position in one go, ballistically. Is that right? Is the right eye reaching its final position in one go? It is not reaching its final position in one go. It is stopping short of it. Afterwards, it is using a slow movement to reach the final position. So when it uses this slow movement to reach the final position, so instead of, when a normal saccade looks something like this, in the normal with small amount of hypometrias, I am writing like this. In this particular saccade, what it looks like is, it goes up to some extent correctly. After that, this is the final position. It is taking a slow movement to reach that. Is that what you see? So these slow movements can be two types. One is when it stops short, it reaches it through a slow movement. Another is when it goes beyond the intended target and then comes back sometimes using a slow movement. Both of these things are considered as glycates. Both of these things are considered as glycates. Fine. In this particular patient, I can tell you the history of this particular patient to see. This patient has an idiopathic intracranial hypertension. We think that in this particular patient, the right side movement, okay, was impaired because of a false localizing sign that there is a pseudo abducens palsy, okay, because of raised intracranial pressure. That is why when you look at the rightward movements only, that is a problem. Can you see that in the graph? Please look at the graph. The right eye movement, there is a problem, only moving to the right. The right eye moving to the left, there is no problem. Can you see that? Okay, that looks like the right side abducting eye is only for the abduction, it is weak. In this particular patient, we know the history, it was a idiopathic intracranial hypertension. Okay, we'll go into further things later on depending on the time, but first we will go to the next category of eye movements. Then if there is time, we will come back to this. Shall we go to the smooth pursuit? Okay, so when you saw the smooth pursuit, the target, how does the target move? Target moves in a sinusoidal fashion. Okay. Target moves in a, is that right? Okay. Target moves in a sinusoidal fashion, and a normal eye movement, eye also will move along the target in the sinusoidal fashion. Is that right? Okay. Please pardon the not overlapping lines. Okay. So the eye also moves like this. Target also moved, exactly. Both of them overlap, which means the velocity of the target and the velocity of the eye was same. They were equal. Fine. We know two things from our previous discussion. Relative alphabets. What are those two relative alphabets? Slow versus fast. So this is slow. This is fast. This is slow with respect to this one. This is fast with respect to that one. Is that right? Now, let us imagine. That is one thing. And then we also have another thing called, okay. Now let us write a trace of the target moving in only one place. Target moving from one side to other side. One part of the smooth pursuit I have taken. The target is moving from the left to the right. Okay. Now just imagine there is an individual who is not capable of slow eye movements. This particular kind of slow pursuit eye movements. What will happen for him is, like, if he is not capable of slow movements, what will happen? The target is moving, but the eye will stay where it is. If it is staying where it is, how does the line look like? How does the line look like? Horizontal line. Fine. So at one particular, this x-axis is the axis that tells us the timing. Is that right? So if at this particular point of time, if I see, what is happening? The eye is not able to move, is stuck where it is. The target has moved. So where is the target? If you see this line, the target is to the right or left? Target is to the right of the eye. So the target is somewhere, okay, eye is looking somewhere here, whereas the target has already crossed this point. It is almost here. Now if this eye is not capable of a slow movement and it was not able to keep pace with this eye, what it will do now? It will now try to make one fast movement and try to reach the same place. This is the place. Correct? You're all with me? All of you want to stand once? Stand once and sit down, please. Yeah, please sit down. Thank you. Okay. So what happened is, the eye had fallen short of the target, then it makes one jump to reach the target. Again, the target keeps moving, eye is not capable of slow movement, so eye just stays where it is. After some time, it realizes the target has gone back, and then it goes up. So you see this right angle kind of movements. So this is called as, what is this called? What kind of pursuit is this called? Saccadic pursuit. This is a saccadic pursuit where the eye is not capable of making a pursuit eye movement. It compensates for the inability to make eye movement, pursuit eye movements by making saccadic jumps. Okay? Now, the other thing, let us see, it is capable of making the slow movements, but not as fast as the target movement. Now what will happen? If the target was moving, okay, if the target was moving like this, if the eye is slower than the target, how will the slope be? Will it be more steeper or lesser? Lesser, fine. So the eye will be moving something like this. So slower than the target. How does it compensate? Again it tries to make one fast movement to reach that. Okay? So we see this kind of a thing. This is called it is going off. The target is going off, the eye is trying to catch up with the target. So this will be called as, what will this be called? Loud. Catch up saccades. Fine. Now, let us now again draw something different. Okay. Now this is the thing that is moving. Let's imagine that the eye is now faster than the, okay, because of an underlying nystagmus or nystagmic intrusion, whatever it is, eye is moving faster than the target. So how will this look like? More steeper or less steeper? More steeper. So it will go like this. Now, the eye has gone further right, but the target is still not come that far. So what is the eye supposed to do now? Come back. Eye goes back, comes back, goes, comes back. This will be called as, catch back saccades. This will be called as catch back saccades. So what are the three things we saw? We saw a clear-cut saccadic pursuit, then another two varieties of saccadic pursuits where they have a specific name. One is a catch-up saccade and another is a catch-up saccade and another is a catch-back saccade. So when you look at the angle, you can make out. You don't have to really keep thinking each and every time what saccade is this, what kind of a pattern of pursuit is this. If this is a clear-cut saccadic pursuit seen in multi-system atrophy, gross cerebellar degenerations, these kind of things. This has, you can see this angle, this is obtuse angle. Can you see this? Here you see there are acute angles, correct? So if you see obtuse angles, they are catch-up saccades. If you see acute angles, they are called, what are they? Catch-back. No, I want a bigger sound. I know we are very near to lunch, but what is this called? Catch-back saccade. So to look back on what all we did till now, we first started off identifying three alphabets: no movement, slow movement and fast movement. Slow and fast movements are relative alphabets. Then we told that every eye oscillation is not a nystagmus. So there are different kinds of eye oscillation. Nystagmus, jerk nystagmus is one of them. Pendular nystagmus is one of them. Then we have square wave jerks, macro square wave jerks, macrosaccadic oscillations. Then we also have ocular flutter, all these things. We went into the specifics of saccades. We knew how a step pattern represents a hypometric saccade, how a oscillation represents a hypermetric saccade. We also saw how a glissade represents the difference in the eye not knowing how far to fire. If it overfires, it goes beyond a particular point, then it comes back. It comes back as a glissade, or it underfires, then it goes to reach the point as another slow movement. That is two kinds of glycates we saw. Then we came back to the slow phase. We compared the slow phase with two things. What are those two things? The slow phase with either not at all having a slow movement, where every movement of the slow moving target, pursuit of the slow moving target is completely done using saccades, small jerks, which is the saccadic pursuit. We saw where some extent of slow movement is possible, but needs to catch up. We saw the obtuse angle catch up saccades, and then we saw where the eye is faster than the target, and therefore there has to be a catch back saccades. Fine? We saw so many different kinds of abnormalities. Shall we proceed further? We are all together? How much more time we have? We have time. Now, we will go to see and identify some characteristic abnormalities that we see on the videonystagmography study. What kind of a eye movement is an optokinetic stimulation supposed to elicit? What kind of an eye movement is an optokinetic stimulation supposed to elicit? Optokinetic stimulation. You are sitting in a car, or you are looking at your co-passenger in the car who is looking outside. When you look at his eye, what is elicited? What kind of eye movement comes? Oscillation. What kind of eye movement? Oscillation. There is an oscillation. What is that oscillation? It's a jerk nystagmus. It's a jerk nystagmus. Is that right? You're all with me? Okay, so it is a jerk nystagmus. Optokinetic stimulation is supposed to actually simulate that particular condition. So if you stand in front of the optokinetic stimulation screen, the eye will develop what? A jerk nystagmus. Now, if you are sitting in front of the optokinetic screen and the screen is moving up and down, it is moving either upwards or downwards, the jerk nystagmus that is expected is vertical. It is supposed to be vertical. Commonly what we see in a person who already has a vestibular asymmetry, that vestibular asymmetry gets unmasked during the optokinetic stimulation, and you see a very common pattern that is there in the second page. Okay, that page is also marked 1. After the hypometria and this pursuit, next thing is this one. Optokinetic nystagmus, horizontal component in vertical. Okay, now see the lines there. Look at the black line. Black line is showing what nystagmus? Vertical nystagmus. Which side beating? Which side beating? Black line? All of you. If you don't know, please tell me. We'll again spend some time. Up beating. Okay. But what is happening to the red line? What is it showing? It is showing a left beating. But here the stimulation was purely vertical. But why did the left beating component come? And you see in the opposite direction also, when the person is given opposite direction of stimulation. In the first one, it was like top to bottom. The screen was moving from top to bottom, so eye moved slowly downwards and started beating upwards. The next one, it was a bottom to top stimulation. The eye moved up and had a down beating nystagmus. That is the next graph. Can you see all of us are together? All of us are together. Raise your hands who all identified this. Second table. Sir, you could not? Okay. Who else could not? I will come here. Okay. So we need to spend some time here. Okay. See, you see the black line there? You see just concentrate on the black line. How does the black line look in the first graph? It goes like this and it comes up. Is that right? Yes, sir? All of you together? Sir, second table here. Sir, you can see? So what does it mean? The eye. Okay, in the beginning we didn't cover the vertical. It was covered before in the previous lecture. So this means that eye is going downwards. Eye is going upwards. Downwards, upwards. Which is slower? This is slow. And this is fast. Is that right? So, which direction is fast? Up. So this is a up beating nystagmus. Second table, sir? Fine. So this was a upbeating nystagmus. When you look at this workbook, the first one, is it showing that upbeating nystagmus? That is the expected nystagmus in a optokinetic stimulation when the screen is moving from top to bottom, slowly moving downwards as the visual field moves, and make a fast saccadic correction on the opposite direction. In a purely vertical stimulation, what is not expected? Horizontal nystagmus is not expected. Some amount can appear because of the goggle tilts, but significant is not expected. So if there is a significant horizontal nystagmus, as seen here, it probably represents that is because of a underlying vestibular tone asymmetry. This person could have probably had a vestibular neuritis on one side, or he is probably being seen at a time when he is going through an acute attack of a Meniere's disease, whatever it is. So we see this. Sir?
Little comment, just if you, the horizontal nystagmus seen here is the direction fixed.
Yes, sir.
So it's a sure note from optokinetic.
It should not change in the opposite direction.
Yeah.
So when you see what Dr. Alfargal is pointing out, that is why we have included two. Just see the next one. Even there, even when it is top to bottom or bottom to top, it is still left beating. The horizontal component is still left beating. So because of that, it is most likely that it represents a underlying vestibular tone asymmetry. So this is the kind of information we get. Like when I ask people, are you using optokinetic? Not much use, so we are not doing all these things. Optokinetic can reveal a lot. Now coming to the next one.
Sir, can I add one more point?
Yes, sir.
So it represents right unilateral vestibulopathy, either due to Meniere's or
whatever reason.
right side.
Whatever.
So it also localizes, helps in localizing.
It also helps,
the
sometimes helps in localizing, yes. Control.
Sir?
Yes, sir.
But you have to report first if that case has a spontaneous nystagmus or no.
Yes, sir. There was a spontaneous nystagmus in that
No,
case.
so this is the spontaneous nystagmus.
Sir?
This will be the spontaneous nystagmus.
Yes, sir.
So
We
it's
see in
not-
patients with spontaneous nystagmus.
Not because of optokinetic.
It is not because of the underlying vestibular tone
Yeah,
asymmetry
it's a
which gets manifest in.
It is the spontaneous nystagmus.
Yes, sir. But what we also see is there are people in whom there is no spontaneous nystagmus, in whom also we see this this thing that we can only demonstrate after a high frequency head shake. That spontaneous nystagmus is not present only on removal of fixation. That gets manifest only after high frequency. That also shows up in the optokinetic. So that is why the utility comes. Otherwise, we can see the spontaneous nystagmus. Yes, sir. Yeah.
I'm going back to smooth pursuit.
Yes, sir.
Now, when you're doing smooth pursuit in a unilateral vestibulopathy patient,
yeah.
you will see saccadic movements. You'll confuse the nystagmus with saccadic smooth pursuit.
Yes, sir.
That also happens. If you look at a smooth pursuit graph,
yes, sir.
our patient
Yeah.
who is acute unilateral vestibulopathy.
Sir,
you'll see
nystagmus
the-
intrusions.
Yeah,
I'm talking about the
yeah,
nystagmus.
Exactly.
Yeah. So in the nystagmus intrusions, what you see is there are two typical patterns in nystagmus intrusions you see in the smooth pursuit. One is that you see catchback saccades in one direction and catch-up saccades in another direction. This is one way in which this looks. The other way, this is one way. The other way it looks is that you only see catch-up saccades in one direction. On the opposite side, it looks normal. These are two ways in which a nystagmus can interfere with smooth pursuit. But we'll proceed with the next thing on the agenda. We have a lot of things to cover, and I am available tomorrow, day after tomorrow for further discussion. Okay. So now the other thing that can happen in this thing is, Dr. Henry, you want to ask something?
Yes, sir.
Yeah.
So what your example you've shown is on vertical tracing.
Yes, sir.
But I frequently find it in even horizontal tracing that you get vertical.
We get. So that is a vertical tone asymmetry.
That also is.
That also we are seeing that pattern also very commonly. Okay, sir. Okay. So now the other thing that we can see in a person with underlying vestibular tone asymmetry is the optokinetic gain also shows is different. On one side, the speed is very much high, whereas in kind of like if the target is moving from left to right versus right to left, the nystagmus elicited one side is more robust than the nystagmus elicited for the opposite optokinetic stimulation. This is what you see in the third page there. Okay, this is a optokinetic gain asymmetry. You can see the gain there, it is written there. For the first one, the gain is somewhere around 0.79 and 0.81 in both eyes. Okay, that is a very robust nystagmus, right beating nystagmus. Whereas when you see for the left beating nystagmus down, the gain is coming to 0.43. So you see a significant gain asymmetry, which is again a feature which again says that there is an underlying vestibular tonal abnormality, a tonal asymmetry. So the next finding that you can see. Okay, shall we proceed to the next item? Okay. One that is not so commonly seen but done test is an optokinetic after nystagmus study. So there was one patient whom we saw who again had post head movements, he used to feel dizzy. Post fast head movements, he used to feel dizzy for a few more moments. The only abnormality we could elicit in this particular person is a prolonged optokinetic after nystagmus. So what you see here is at the 62nd second, you see the next graph. When you see the nystagmus, there is significant nystagmus. I'll use the correct color. I'll go back to that. Can you see the next page? Optokinetic after nystagmus. Up to 60 seconds, you have intense nystagmus. After that, we stop the optokinetic stimulation, but the eyes don't stop. They continue to show a nystagmus. This is a optokinetic after nystagmus. There are several studies which tell that it is prolonged in some people, some conditions, and excessively shortened in some other conditions like that. But the idea of this particular thing is that, okay, post optokinetic nystagmus also, the velocity storage can continue and lead to the persistence of nystagmus for some time. Next is even more important. Go back to the next page. Optokinetic gain saturation limit. Okay, optokinetic. Look at this particular person. The first graph shows, are you on this page? Optokinetic gain saturation limit, all of you? All of you? Yes, thank you. So, ma'am, you have a question? Or you said yes? Yes, thank you. Okay. So what you see here, left to right stimulation, if you do only left to right stimulation, it looks like everything is normal in this particular person. You see the gain to be even little more than normal, almost 1 unit gain, which means the speed of the screen and the speed of the eye is almost matched. But the same individual, you increase the speed to 20 degrees and you see the difference. The gain is falling to 0.24, 5 times fall in the gain. 5 times fall in the gain. Had we not done this, we would probably label him as everything is normal in his videonystagmography study. This patient, okay, this particular patient, okay, I really don't know the explanation for why exactly this optokinetic gain saturation has happened. There are several reasons written for that. Okay, in this particular patient, the clinical history is he had suffered tuberculous meningitis. Okay, and this is the only thing that we could find as an abnormality. So that was in the optokinetic. Next page. Sir.
Did you repeat the testing was 20 degrees optokinetic
20
many
degrees.
times?
3 times, sir?
You repeated many times, it's constant finding, or just one time done with 10 degrees and one time done with 20 degrees?
It was one time done with 10 degrees, one time done with 20 degrees. Probably next time we'll keep this in mind and keep repeating it.
Yeah.
Okay, sir. Okay. The next thing, the first one you see, it is just about identifying them. We can all spontaneously. How many you can immediately identify, see what is there so that we can proceed? The first graph. Okay. Right beating nystagmus. How many can make out that there is a right beating nystagmus in the first graph? Who cannot, please tell me so that I can spend some time. No. The first graph, head shaking nystagmus. Can you see that, ma'am? So there are 2 components in that there. You see one place where there is an intense oscillation of the eyes. That is the place where the head was being shaken right and left. That was the head shaking phase. After that, when you see the red line, you see that it looks like this. It looks like this. Can you see, ma'am? So this is the, this line is slow or fast? Towards left. This line is fast. Towards the right. So this is a right beating nystagmus. Next you see the first example that we took. Direction fixed nystagmus. Can you see? There is a right gaze, there is a left gaze. On the right gaze also, the eye is beating to left. On the left gaze also, left. Is that right? Who all can identify? Who could not identify? Please tell me. Direction fixed nystagmus. Please raise your hands. 1, 2, 3. Fine. Fine. So I will draw that. When you see the direction fixed nystagmus, I am just drawing the red line. You see this? It is, this line is not seen there, but then for reference I will write. So if the eye was in this particular position versus the eye is in this particular position. Fine? Okay. So when the eye is here, it means eye is looking to the right side. When the eye is looking to the right side, you see the eye movement like this? Yes? So there is a, which side beating is this? Left beating? Yes, sir? Sir? Yes, sir. Yes, sir. Okay. So this was left beating. Anybody else needs explanation? Fine. Now, the eye, this was like this, and then eye goes to the, here it means the eye has gone to the left side, because down part of the graph means left side. Now here also, what is the oscillation pattern you are seeing? Is that right? Okay, it is not, it may not be that, at that zoom level it may not be very manifest, but you can make out that it is again left beating. Okay, so this is the direction fixed nystagmus. Okay. Then direction changing nystagmus after hyperventilation. Can you make out that? Can you make out at which point in time the direction is changing from, if you look at the second part of the graph you see, don't ignore the first part of the graph, second part of the graph when you see, you tell me at which particular point of time left beating nystagmus becomes right beating. 90, 89, 90, is that right? Around 89, 90 you can see that the nystagmus was, this is only the blue line, you can see there. You can see there that it was right beating like this, exactly around the 89th segment or something like that. Sorry. Other way around, yeah. Thank you, sir. That gives me a lot of happiness that yes, sir. Yes. Okay, sir. So when you see this, it looks like this. Somewhere around the 89th second, suddenly it starts. Can you make out? Everyone?
Sorry,
Yes, sir.
Srinivas.
Yes, sir.
So in
Left beating becomes right beating. Yes, sir.
in the first one or what?
This is the third direction changing nystagmus after hyperventilation.
Second,
Yeah.
there is direction change and again there is direction
That's
change.
after hit the, okay.
Yeah, if you see, sir, at 66 seconds, there is a change from right to left.
At the 66th second, there is a left beating. It is
Left beating.
continuing to be left
But
beating.
But sir, at 10th and 22nd, you see, it is right beating. And
Yeah.
it became left beating.
Yes, at the 10th to 22nd, it was right beating. Then it became left beating. Then again, it became right beating.
Right
Super,
beating.
wonderful. Okay. Okay, that's nice. Super. Shall we proceed to the next item? Now you can see the next one. Again, similar thing, biphasic nystagmus of high frequency head shaking. Can you see that? What is the initial nystagmus? Everybody, initial nystagmus? Only this corner. Okay, initial nystagmus is left beating. The next nystagmus is right beating. Fine. Then again we have further examples. We had a patient who had hyperventilation induced nystagmus. This is a case of vestibular paroxysm. He had a cross compression right at the root entry zone. So this patient did not have a spontaneous nystagmus. His nystagmus appeared after hyperventilation, and that even within some 10 seconds of hyperventilation he started developing this particular nystagmus. 10 or 20 seconds of hyperventilation. You can see that hyperventilation induced nystagmus. Which direction is it beating? Which direction is it beating? Right beating. Who all cannot make out, please tell me. There is a vertical component as well. Wonderful, sir. Downbeating component. Downbeating vertical component. Anybody needs explanation? Sir? Yes, sir. Anything specific, sir? Or you want me to draw that and explain? Yeah. So hyperventilation induced nystagmus, when you see that, okay, if you can see that the jerks look something like this. Okay, I'll use the correct color. Okay. The jerk looks something like this. They are very, very short because I used a very, it is like this. So there is, this segment is the slow segment and this particular segment is the fast segment. So it is which side beating? Which side beating? Right beating. So there is a right beating hyperventilation induced nystagmus.
Sir, 1 second, can I add one more point?
Yeah, please, sir.
And we can suspect in this patient right beating, na? So
Yeah.
he must be having left vestibular paroxysmia.
Could be.
Because- Yeah,
Yeah,
could be.
could be,
Because
could
it
be.
in vestibular paroxysmia there is
Yeah.
initially
I knew this question you are going to ask. I tried to remember which side. Unfortunately, in the note, I had not written in the notes the MRI find. Okay, sir.
Okay, okay.
Okay, sir. Yes, sir. Yeah. Inferior. Yeah.
But if it is outside,
Yes, sir.
if it is outside the canal,
Yeah.
it becomes one entity.
Yes, sir.
So if we just extrapolate to what, I'm sorry, I don't know.
I will answer. Vishal.
Yeah. So depending upon
Yeah.
where the compression is, if it's inside the canal, it could compress either the superior
Yeah.
or the inferior.
Yeah.
So it could be same-sided or opposite-sided.
Yes, sir. It
But
can
if
be
it
say.
is-
Yeah.
If it is in the
Yes, sir.
CP angle,
Yeah.
outside the canal,
Yeah.
then what Dr. Vishal says is
And
correct.
even within that, it also depends on the extent of damage.
Definitely.
Yes, sir.
Definitely.
Like
See,
it is inhibitory or excitatory.
And
Yes, sir.
I still believe that we still haven't understood vestibular
Yes, sir.
paroxysmia to its complete extent.
Yes, sir. Yes, sir.
No, I would add one more point.
Yes, sir.
Do we
But
have
there is
time?
something on the agenda also. Time's up, it is showing. Okay, no problem.
It depends on transitional zone. It
Yes,
is
sir.
not the vascular
Yeah.
compression
Yeah.
in CP angle. CP
Yeah.
angle will cause the vestibular paroxysmia,
Yeah.
not in the internal auditory
Yeah.
meatus.
Yeah. The main thing is still pending. Okay, that is the BPPV. That is the one that will give us a high. Okay. Because all this looks like we are hanging somewhere. The next one is the big thing on the agenda. I'll take 15 minutes for that. And I'll come in the way of lunch. Okay. I think you will allow me to continue till 1:15?
Yeah, go.
Sure? Okay, thank you. Okay. Now the next one, fixation suppression of caloric nystagmus. Of all the things that we do on caloric, the most important according to me, if you do a caloric, please do a fixation suppression because that is going to tell us that the fixation mechanism, ability to suppress a vestibular nystagmus exists, which means that some of the central structures are normal, especially the cerebellar flocculus. Okay? So, fixation suppression of caloric nystagmus. There are two phases you can see. You can see something in gray and something in green. Can you see the markings? Okay. So here what you see is what is written in gray. There is intense nystagmus. Then in the green segment is the time where the fixation was induced. So beyond a certain line, fixation was induced. And suddenly, what is the difference between the slope of this slow phase versus the slope of this slow phase? Which is slower? The second slow phase is slower. All of you agree? The slow phase slope is lesser, or the slant is lesser under the green compared to the slants of the lines just before the green. All of you agree? In the workbook? Big guess. Yes. All of you stand once, please. So that is fixation suppression. Okay, that is fixation. You want to stretch? You can. Please stand up and stretch. You can. Please once. We'll take that one more break. Stand up again. Yeah. We deserve this. Okay, stretch. Yes, sir. Thank you. So the same thing is also written down in the values that you can see that slow phase velocity in the prefixation window versus the fixation window. The slow phase velocity is much lesser in the fixation window compared to the prefixation window. The next thing is the next one, this is something that big we are going to do. We are going to look at this line graph and tell exactly what is going on in the inner ear. Does that look exciting? You look at a graph and tell what is going on in the inner ear, because the inner ear, the fluid flows, you are not amenable to any other way of looking at them. The best way of looking at what is happening inside the inner ear is by looking at the eye. Shall we undertake this? Okay. For this we need to do a small exercise, all of us. So, if you hold your thumb front and you move your head right, you move your head right. In what direction your eye moved? Eye moved to the left. What moved your eye to the left? What moved your eye to the left? If it was a very fast movement, it was the right-sided horizontal semicircular canal. Is that right? Yes or no? Yes. Now let us see what exactly of what we know. When the head moves to the right, the fluids, because of their inertial lag, basically move to which direction? In which direction? If the head moves in this direction, the inertial lag keeps the fluid where it is, which means for practical purposes the fluid has moved in the left. So when the head moved right, in the horizontal semicircular canal, the fluid moved in the left. Is that right? All of us are together? This is very important that all of us are together, otherwise we don't follow the next. Okay, so when the head moves right, inner ear fluids move to the left side. Correct? Now, when the head moves right, in order to be able to keep fixing where we want it to fix, eyes move to which direction? Left. Is that right? So the vestibular driven eye movement moved to which direction? Left. Correct? Now can we just make one small next conclusion here? The eye movement direction, the vestibular phase of the eye movement direction and the inner ear fluid movement direction, both are same? Yes? So, if the inner ear fluid is moving like this, the eye also will move? Yes? Which means if it is continuing to move, eye meets the limits of the orbit and then comes back, comes back. So, if the fluid is moving like this, then nystagmus will be beating? Beating? Opposite, correct? Correct. So, if the fluid, you can see the nystagmus beat direction, opposite direction is the inner ear fluid movement direction. Correct? So, if there is a right beating nystagmus, probably it can be because of fluid moving towards the left side. Right beating nystagmus, fluid moving towards the left side. Correct? Shall we now look at one particular index beautiful patient case and then look at the nystagmus and tell what is happening to the inner ear fluid movement. And that will be instructive, that will become a strong foundation for us to start interpreting every other positional maneuver. Shall we embark on this short journey? Yes. Today morning you saw Dr. Manoj Agarwal's presentation on the temporal bone anatomy. Now when you saw the temporal bone anatomy, horizontal semicircular canal when you saw, was it looking like a C like this, or was the horizontal semicircular canal looking more curved like this, back? First or second? 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 All of you agree? Okay. Now, in an upright patient, if this is the nose and this is the occiput, whatever, the horizontal semicircular canal is placed 30 degrees to the horizontal. Is that right? If this is the horizontal line, it is placed 30 degrees to the horizontal. Is that right? So, if this is placed, this is the curved thing which is placed 30 degrees to the horizontal. If you look here, fine. This particular place, this particular place, the posterior end of the horizontal canal will correspond to this part. Correct? Yes or no? That is the posterior most part. And when you know this anatomy, you know the most dependent part in this horizontal semicircular canal will be this part. Correct? This is higher up. This will be higher up because they are all front. The most dependent part is this part. Correct? You are all together? So I'll redraw that. So now I will draw a horizontal semicircular canal. I may exaggerate this a little bit for this thing. Now let us imagine this particular patient in an upright position. This is the most dependent part, and there is some debris sitting here. Okay? Today morning you are listening to Dr. Vishal Pawar make an intervention about reaching a position from which position. These things become important. So in this upright position, this particular, I am only talking about this patient. We are not going into controversies here because the most important thing here is to understand what is going on. Other discussions we'll do later. Now for me, if this is me, if this is my horizontal semicircular canal like this, if this is the most dependent part in the upright position with my head like this, now if I go from this position and go on to sleep, if it was already there in the most dependent position, if I go to the supine position, will this move? Will this move? It is not going to move because in the sitting position also, it was there. Even if I lie down also, it is there. So it has not moved, this debris. Now take this right geotropic lateral canal BPPV, the last page, right, geotropic lateral canal BPPV, McClure Pegnini, supine from sitting. The first graph, supine from sitting. You see a nystagmus there? Do you see a nystagmus there? No nystagmus. Previously what we said? If there is a fluid movement, there has to be eye movement. No eye movement, no nystagmus means there was no fluid. There was no fluid movement. Fine. Now, the next thing, right geotropic lateral canal BPPV, McClure Pegnini, right lateral position. From the supine position, the person who was sleeping like this turns to the right lateral position. So what will happen? I will draw that here. So I will draw that here. Shall I? So from this, I draw the next thing here. He goes to the right lateral position. So if I roll to the right lateral, if I am seeing this person from the head end, isn't this how the horizontal canal will be oriented with respect to gravity if this is the ground? Okay? Yes or no? Yes. Now, the debris was here. Right horizontal canal, the debris was here. Now the debris gravitates to the dependent position. So where does it go? In this direction. Is that right? And it reaches this pit. Yes or no? Yes. So what is supposed to happen? Inner ear fluid is moving in this direction. Correct? Which means my eye will move slow to the direction. Expected nystagmus direction is right beating. Just see if there is a right beating nystagmus in that particular graph. Can you make out a right beating nystagmus? Isn't this nystagmus looking like this? In the beginning, it is so intense that the slow component and fast component look almost same, but as you keep seeing it, the difference becomes manifest. Correct? Can you see that? Yeah, around you as you progress, it becomes more manifest. Okay. We are used to saying that vestibular is slow phase and saccades are fast. But sometimes in lateral canal, the slow component or the vestibular component is so fast that it is comparable to the saccadic phase. That is why in the beginning you can't make out the difference. But as you see further, can you make out that there is a right beating nystagmus here in the second graph? All of you can make out, please raise your hand. There is a right beating nystagmus. By what we saw from looking at it on turning to the right, we expected a right beating nystagmus or no? Yes. We expected the eye to move slowly to the left and beat to the right. Correct? Now let us see what happens next. Vertical graft, I'll come to that, sir. I'll come to. There is another 20-minute video I have made on why we see all these things. Okay, sir. The first thing is to I have to finish off this one particular concept that I want to drive. Okay. Yes, sir. Now, next thing is this. Now from this position, the person comes back to supine. Okay? The person comes back to supine. So from here, he was in the right lateral position. From the right lateral position, this was to the right lateral. From the right lateral, he goes back to the supine position. Okay? He goes back to supine position here. Now what will happen? This had reached this place. Now from here, it has to again go back to the most gravity dependent position. Yes or no? Now. So, I was to my right. Now I go back to the supine. So the debris starts moving like this, which means the eye slowly starts moving to the right. The beat direction should be to the left. Do we get that? See the next one. Right geotropic lateral canal. The naming is in one page. The graph is on the other page. Supine from right lateral. What is the nystagmus that we were expecting? The nystagmus we were expecting was left beating. So did we get a left beating nystagmus? Yes or no? Yes. So are we now looking at the eye and telling what is happening in the inner ear? Yes. Now from this, now I want you to notice this one thing here. When the person went from the sitting position to the supine position, sit to supine, the first graph, there was no nystagmus because it was already in the most dependent. Again it is in the most dependent. When it turned to the right and went back to the supine position, now there is a movement. That is why in some times, first time supine you don't see a nystagmus, second time supine there is a nystagmus, because it is not just the position, it also depends on from which position you reach that position. Okay, because that would have altered in BPPVs. This is very important. Okay. Okay, sir. We'll finish this, sir.
Only
We'll
one
finish.
sentence can
Yeah,
I add?
please.
If you see the first graph, there is left beating nystagmus. When the patient went supine, there is
Yeah.
left beating.
Yeah.
There is left beating nystagmus
Where, sir?
in the first graph. Because if it is a geotropic nystagmus,
Yeah.
when the patient lies down,
Yeah.
the nystagmus will
Sir,
beat
a
towards-
small little bit of this. I'll go to the controversies later. The main thing is to drive home this point as to look at the eye and determine what is happening in the inner ear. Okay, so that is the one. So you saw this. So that is why in the second time when the person gets into the supine position, you saw this left beating nystagmus. Now we turn this patient over to the opposite side. When you turn this patient over to the opposite side, this is what happens to the lateral canal. Okay? When you turn this patient to the opposite side, this is much more peaceful with the ACs off. Okay. So here, when you saw this, now this one debris had reached this particular position, which means the debris had reached this particular point. From here, the gravity most dependent is here. So again, the debris gravitates to the lower part, which means now the eye has to, this thing is moving like this, fluid is moving like this in the horizontal canal, which means the slow phase of the eye movement should go like this, and the fast component should be, which be? No. Left beat. Okay, it means left beat. I got confused, left beat. Time to give a break, and I may also have a lunch. So it is supposed to be a left beating nystagmus. You see that? It goes to the left lateral. Are you getting a left beating nystagmus? Here? You see a left beating nystagmus. So when it turned to the right, there was a right beating nystagmus. When it turned to the left, there was a left beating nystagmus. So this is on the right beating, on the left beating is considered as geotropic or ageotropic? Geotropic nystagmus. Okay, geotropic nystagmus. Now the same person, from that he comes back to the supine position. He comes back from here back to the supine position. You see this? He goes back to the supine position. It was here, then the debris comes here, which means again the movement direction is like this, which means the eye from here, okay, goes in this direction. Correct? Then you are supposed to expect a right beating. Are you getting a right beating nystagmus? Yes. Okay, you are getting a right beating nystagmus. So this thing, this particular example I chose to tell that you can look at the eye and then reach a conclusion as to what exactly is happening in the inner ear. This was about this particular for the benign paroxysmal positional vertigo. There are some differences, patterns that can be seen when multiple canals are involved based on so many other factors, where exactly in the initial position, which was the most dependent position because of anatomical factors. All those things we can do discussion. But the main thing here, the intention here was to make a strong foundation as to how you can look at the graph and find out what is happening in the inner ear. That is the number one. So we first started off with alphabets, then we made some words, then using those words, some conclusions we are making. Then the next thing is actually sentences. Now what happens when we look at videonystagmography and all these things is, we see something called saccadic pursuit. And then we want to see what are the causes of the saccadic pursuit. We get some 30 causes of saccadic pursuit and we are lost. We see something like hypometria in saccards, and then when we look up the book, hypometria in saccards, they are seen in some 20-30 cases. And we are lost as to where exactly this is the problem. That is why we should not stop at words. Only saccadic pursuit, only macrosaccadic oscillations, only hypometria, only hypermetria, only glycide. If you see, we are still at words. Now, how to form sentences out of these words is take a combination of findings, and that is exactly what is written in the next thing, that material that we have shared, this one. Okay, here I will just take one example to just drive home the point how to make the sentences. Okay, so I want you to go to just one page, we will see. Okay. I will give you the page number. One simple thing we will do. The easiest one to follow. Yeah, just give me somewhere cerebellar vermis or something like that. Will be easy. Yes, go to page number 8. Page number 8, clinical findings with lesions affecting the dorsal vermis, fastigial nucleus, uncinate fasciculus, so much is written. So it is not about taking one thing in isolation. If you see dorsal vermis lesion, there are 3 things that are told. It says that when you do a saccards, you will see a ipsilateral hypometria and a mild contralateral hypermetria. So there is some kind of a pulsion that is seen in the saccard test. So if it is only the saccard finding, it will be word, hypometria, hypermetria. But if you see saccard finding with gaze is tonically deviated away from the side of lesion. So when you see this particular patient, if you see, especially if you want to see tonic gaze deviations in a particular person during VNG, a best way of doing it is, see, when you are doing the calibration, we know that the center position of the eye is somewhere around 0. So when you actually mark this, get a tracing of this particular patient in spontaneous in light, the eye will be like this. Even though this patient may not have a nystagmus, if you remove the fixation to this particular person and ask him to look where you think is straight ahead, instead of looking like this, he starts looking here. He thinks either the right or the left is his true straight ahead. This is the gaze deviation that you will see. Gaze is tonically deviated away from the side of lesion. Smooth pursuit is impaired for targets moving towards the side of lesion. So what does this mean? This means if the lesion was on the right side, the smooth pursuit will show a particular pattern where the pursuit towards the right only is impaired, whereas towards the left, it goes normal. If the target is moving towards the right, you see a saccadic pattern of pursuit. When the target is moving to the left, okay, this kind of patterns. So this is just as an example, not as a comprehensive coverage. The comprehensive coverage is there in the book, but you should start forming sentences like this so that we can reach very nice conclusions. Hope that was helpful. Okay, thank you all. Thank you so much. Thank you. Shall we proceed for lunch? Yes, sir. Yes, sir. Yes, sir. Why is lateral canal BPPV more intense to one side versus why it is less intense to the other side? In fact, this is the point which we make, which we use to find out which is the affected side. Which is the affected side. In one particular direction, when we look at the full detailed explanation 5 minutes or short explanation 2 minutes? Shorter, how many for detailed 5-minute explanation? Good, super, great, thank you.
This was a very nice session. May I call Dr. Alfergal to give moment to Dr.
No, 1
Srinivas?
minute, we are not yet done. We are not. Okay. So, when you look at the structure of the hair cell, this all relates to the structure of the hair cell. When you look at the hair cell, there is something called the kinocilium, and there are the stereocilia. Fine? There are the stereocilia. From the kinocilium to the stereocilia, to the stereocilia, to the stereocilia, are what? Tipplings. What are these tipplings? Where do they attach to? What purpose do they serve? So if you look at one stereocilia here, there is a small molecular door here. This tippling is attached to this molecular door. This molecular door at every point in a person who is, when the hair cell is undisturbed, in its undisturbed position, not this way or not that way, this particular door is partially open. Partially means little open, not half open, not near full open, little open. Now, when the kinocilium moves in this particular direction, this molecular door opens fully by this tippling. When the kinocilium moves in the opposite direction, this particular molecular door, from here, it just closes shut. Okay, it just closes, latches shut if it moves in the opposite direction. So, if the kinocilium is pulling this in one direction, it starts going like this. If the kinocilium goes in the opposite direction, it lets the tippling is loose, it just goes and closes. Fine? Now this is the mechanism that happens with the kinocilium movement right or kinocilium movement to the left. This is number one. Now, what is the function of this molecular door? To let ions inside. When the ions go inside, the next level of action happens and the degranulation and then the synaptic release and then the action potential generation, whatever it is. Now, the thing that is very important here is, even in the neutral position, when the kinocilium is either not disturbed right or not disturbed left, in this particular position, also the molecular doors are open. Means in also the action potentials are generated. This action potentials train becomes more frequent or more robust when the kinocilium opens in this direction, and it becomes less robust or goes to zero when it goes to this side, when it is completely shut. Okay? This one. Every hair cell has one direction in which it becomes more and more open, another direction in which it becomes closed. Now in the lateral semicircular canal BPPV, one direction flows in the direction in which these molecular doors are more and more open, another direction in which the molecular doors go shut. Now let us see what is the difference. In one direction, as the speed increases of the fluid movement, little movement, as the speed even more increases, little more open. If the speed becomes even more open like that. So the limit for saturation is very high on the excitatory direction. So from 60 action potentials from second, it can go to 200, 300, 400, 500, 1000 like that. Whereas in the opposite direction from 60, when the kinocilium goes in the opposite direction, it can only reach 0. It won't go beyond it, irrespective of the velocity of the fluid movement. So in the horizontal canal, it's in the right side, when I turn to the right, when the fluid moves in this particular direction, it is in the excitatory direction where this becomes open, more and more open. You get robust nystagmus. When it moves in the opposite direction, it is shutting it closed. How much ever fast it is, little speed is enough to close. But after that, how much ever you increase, it is not going to be represented as a change in the action potentials generated. So you have a limit to the extent to which the velocity can be reached in the opposite direction. So one side you get a very high robust nystagmus, for the contralateral flow you get a less nystagmus. Did that answer the question, sir? Yes. Yes, sir. More robust than the excitation. Again, as Professor Alfargal put it in English words, semicircular canals are optimistic. Okay, they respond to excitation more than to inhibition. Yes, sir. Thank you all. Thank you. Thank you. Thank you.